Hello everyone, this is Jasprit Bat, second year internal medicine resident at Central Michigan University College of Medicine. Today I will be presenting a case of double fistula, streptococcus mitis, culprit behind chest wall swelling. Pleurocutaneous fistula is an abnormal communication between pleural cavity and skin. It can occur as a complication of infectious process, neoplasm, foreign body aspiration, and as a post-surgical complication. Among infectious causes, tuberculosis is the most common cause associated with pleurocutaneous fistula, and infection with streptococcus mitis causing pleurocutaneous fistula is very rare. So let's get to our case. We have a 55-year-old male who presented to the emergency department with anterior chest wall swelling associated with productive cough and fever for 6 weeks. Initial vitals were stable. On general examination, patient had a poor dentition and 10 centimeter fluctuate swelling with overlying erythema and tenderness on the anterior-inferior chest wall. On auscultation, chest examination was positive for decreased left-sided breath sounds. Lab work was ordered, which was pretty much unremarkable except WBC count of 16,000. Imaging was ordered, which revealed left lung mass with left lung pleural effusion. CT chest was ordered to further delineate the lesion, which showed multiple necrotic lesions bilaterally, as we can see here in the axial section of the CT, with left pleural effusion and an anterior chest wall swelling with air fluid levels which seem to be communicating with the left loculated pleural effusion here in the axial section. Similarly, in the sagittal section, we can see here left lung pleural effusion and anterior-inferior chest wall swelling with air fluid levels. So with the suspicion of empyema with this loculated swelling, patient was started on broad-spectrum antibiotics, cefepime, vancomycin, and metronidazole. Infectious workup was ordered, which was unremarkable. Echo was also ordered, which was negative for any valvular vegetations. Surgical team was consulted. Patient underwent left thoracotomy and decortication with drainage of the abscess, repair of pleurocutaneous fistula, incision and drainage of chest wall abscess was performed. Intraoperatively, a duodenal hole communicating pleural cavity through the diaphragm to the chest was found and was repaired via laparotomy. Pleural culture fluids were sent for analysis, which were positive for streptococcus mitis. So after the surgery, patient's symptoms improved significantly and patient was discharged on 4-week course of ampicillin and sulbactam. So pleurocutaneous fistula can present as a chest wall swelling or as a draining sinus. It depends upon the etiology. If it is occurring as a complication of infection, it can be red, tender and draining, or if it's just occurring as a post-surgical complication, it can present as a non-draining swelling. Differential diagnosis of the chest wall swelling is broad, which includes lipoma, abscess, sebaceous cyst, skin cancer. If it's occurring as a post-surgical complication, it can occur due to hematoma formation, seroma, lung hernia, any infection, and metastasis. Risk factors for streptococcus mitis include alcoholism, old age, lung cancer, diabetes, and hypothyroid. X-ray is a initial investigation, but CT chest is investigation of choice for better delineation. And other tests include MRI thorax and transcutaneous ultrasound. Management includes early diagnosis, surgical repair, and prompt treatment with appropriate antibiotics. So in summary, this case highlights importance of considering pleurocutaneous fistula caused by streptococcus mitis as a differential diagnosis in any patient presenting with chest wall swelling, especially with poor dentition and alcoholism. Thanks for listening and have a good day.